Moving into the next chapter, and actually two chapters together. Renal compromise, dialysis and transplant. I will have to read the slide, but the colored ones. What is the problem with chronic renal disease, CRD? Here comes the area which gets a bit complicated. The first ones, like cardiac patient, the diabetic patient, the thyroid patient, the pregnant patient, those are quite straightforward and we have discussed before. Kidney and liver are two organs which are so multifunctional that the problems from these organs come in different ways. So what are the different ways? This patient has got a greater bleeding tendency, a patient on any of these, specifically CRD, hypertension, renal hypertension, anemia. Of course, if the renal condition is there, chronic renal condition, there will be anemia. This patient will be drug intolerant because of the huge number of drugs having their metabolism finishing at the kidney. Increased susceptibility to infections, the immunity is reduced, and the presence of several oral manifestations in association with either disease or its treatment. Because COPD patients are also treated with steroids. They require, sometimes if they are requiring dialysis, they will get heparin on a regular basis at the time of dialysis. So with all those things taken into account, cyclosporins, all these things taken into account, there may be problems due to the disease or due to the treatment of the disease. Just remember, up to 90% of patients of CRD will have oral manifestations. So if you are treating with a patient with CRD and you are looking at the mouth alone, just remember that the main cause may be hidden in a kidney disease. Blood urea increases in CRD, both in blood and in saliva, urea is increased. So there is a characteristic halicosis. Some will give metallic taste and burning sensation as well. Same thing. Reduced fluid. These patients are under fluid restriction. So reduced fluid will cause reduced saliva, increased plaque and calculus and decay. Pale anemic mucosa with erythematous lesions. There are patchy erythematous CRD lesions in these mouths sometimes. Demineralization of jawbone will be seen on the OPG. There will be unexplained mobility and tooth loss, leading to next step is poor healing after the tooth loss, and eventually there can be an osteomyelitic condition, septic or aseptic, and that can lead to easy fractures. Bleeding tendency will be there, multifactorial, both disease and treatment. Due to reduced immunity, there will be candida and HSV. There can be gingival overgrowth, mainly due to drugs like the antihypertensives and the cyclosporins. So this spectrum is important. When you are seeing a patient for a oral condition and the patient has CRD, then many of the conditions are due to the poor control of the CRD. So there you have to look into it and treat these patients in conjunction with the person looking after the renal condition. And be careful about situations like this fractures, bleeding tendency and all. Now, again, don't just look at the chart, don't go into it. This is a complex chart, again kept for medical legal purposes, where from I come with my conclusions. CC is creatinine clearance. All I need to make clear in your minds is creatinine clearance and serum creatinine are not the same and they are not just reverse of each other. Okay, because the normal standard blood test that we recommend mostly for renal evaluation is serum creatinine. But whether this patient is poorly controlled renal failure situation, CRD or not, is defined and drug doses are defined by CC, that is creatinine clearance, not by the serum level of creatinine. However, fortunately there is a link, and unfortunately the link is very complicated. First of all, just let us take it as CC 10 to 50 and CC less than 10. CC is a reverse factor. Lower the creatinine clearance, worse it gets, because the kidney is functioning less and less. So kidney function with a CC of 10 to 50 ml per minute is in a better shape, and below 10 per minute is in the poor shape. So all the other medicines almost remain same. There lies the big advantage. These are the medicines that we normally use. Amoxicillin, no problem. Amoxiclav, almost no problem. Penicillin G. Have any of us ever used penicillin G? I don't think so, so I will not talk about it, but just that we need some alterations. Clindamycin, we were very scared about because of clindamycin being a son or grandson of erythromycin, which was the first medicine that gave rise to pseudomembranous colitis. So somehow from student days, this clindamycin group has got a worry in the mind of the prescriber. There is not really any need, at least in the case of this renal failure patients. Clindamycin can be given without dose adjustment, so is doxycycline, erythromycin. Now metronidazole is a problem. Not a problem, little bit of alteration but hardly any. Up to a moderate level of CRD, you can give in the standard dose, 8 to 12 hourly. Our normal dosing is usually 8 hourly. So up to a moderate level, it is fine, same dose. At a very poor condition of CRD, you reduce it to 12 to 14 hours. That is BD or OD dosing. That's all, but the main dose of 400 milligrams remain the same because the dose range is 250 to 500. At this level, the patient will start giving you major histories. This will be a patient who visits the hospital often, probably for dialysis. Azithromycin, no need of dose adjustment. Amphotericin, again something we don't really often use. But fluconazole we do. Fluconazole, there is mild difference, but I think we usually stay within this range. We usually give this, often give 50 milligram, but up to 200 milligram is safe in a day, and almost same over here, 50 to 100. That means even fluconazole does not require much of dose alteration. So, why I bring this up and all these details, apart from penicillin V, which we hardly use, there is very little change in medication required for patients of chronic renal disease. So, with the next patient who comes and gives a renal history and expects that there will be a lot of twisting and turning of the dosage of medicine, that is not really necessary, and that's documented. For the other things, paracetamol, aspirin, ibuprofen, dihydrocodeine. Dihydrocodeine we hardly use, that's why forget about it. Ibuprofen, no need of dose adjustment, no need of dose adjustment, no need of dose adjustment for paracetamol and ibuprofen. Aspirin, again another medicine that we have almost stopped using in dentistry. You cannot use aspirin. Aspirin is contraindicated. Just remember this, aspirin is contraindicated in chronic renal disease. But the rest of the medicines that we use, almost the rest of all of it is quite free. Now, this is the calculation. Okay, it looks very complicated, and we will not get into it very much. Thus, individuals with average body weight corresponding to his or her age and have a normal serum creatinine level between 0.6 to 1.2, which is the normal level of creatinine, would have a creatinine clearance within normal range of 75 to 127. Normal is 75 to 127. And we were talking about problems in cases of 10 to 50. Only at the level of 10 to 50 creatinine clearance a problem starts ensuing. However, the slide before this which showed all those oral conditions, those are valid from the very beginning. Those are valid from the early CRDs also. So remember that side, look into that side, and don't worry about the common worry of dose regulation and inability to prescribe medicines in renal cases. 75 is the range. 50 to 75 is a buffer zone where you will probably get some oral manifestations, but you will not have to interfere with the dosing of medicines. Hemodialysis patient. So CRD got much worse and now the patient is in dialysis. Remember, this patient will be in a high prevalence of arterial hypertension, platelet dysfunction and anemia will be problems, so there will be bleeding tendency. Remember that this patient is getting dialysis, so heparin is going into the patient every time the patient is going for dialysis. Perform dental treatment the day the patient is not receiving dialysis to be sure that there is no heparin in the blood. Mean life is 4 hours, 6 hours is the maximum that we discussed about. So heparin anticoagulation is the issue. Perform dental treatment the day when the patient is not receiving dialysis. We usually choose for treatment the day immediately after dialysis, when we need to do a procedure and when we need to medicate also, because then the medicine will stay in the blood, medicine work will be there for the next part of the week. till the day that the patient is going to get dialysis, then all of it is washed out again. So that is the best day for procedures. Disturbance in metabolism and removal of drug, which we have discussed very clearly in the previous slide. So forget about it, just remember there are disturbances, but those disturbances become significant to warrant for a major change in dose only when things are very bad. These patients might be on corticosteroid therapy. So we discussed about corticosteroid therapy in the slides before. Remember that for these patients will be immunosuppressed. So prescribed antibiotic prophylaxis is recommended by the nephrologist prior to certain treatments. Or you do that anyway. Gingival overgrowth. See, these are international data. Abroad, to prescribe antibiotic, you have to have a distinct cause. Otherwise, you may be questioned. I distinctly remember as a junior house officer, I was prescribing coamoxiclav also for skin laceration infections. And I received 2 letters because I made 2 prescriptions from A&E. So I received 2 letters 2 days later in my box. Those were still the days of letters, not emails. So I received 2 letters where it was clearly mentioned that we have a medicine called flucloxacillin, which is the medicine for staphylococcus. And external skin incisions have bacteria which are susceptible to flucloxacillin. So I believe your prescription of coamoxiclav was not appropriate. This is not an intraoral infection, where there are streptococci who are more responsible for the infection. That's how antibiotics are controlled in the developed countries. That is why this discussion has come in. But for Indian circumstances, we almost give antibiotic clear. Finally, gingival overgrowth. Or no, we know about gingival overgrowth, we talked about it. So we'll move on to another mega topic, again, not plenty of slides, 2 or 3 only. How does a liver disease affect a patient who requires dental treatment? This is mostly directed from extraction point of view because all the rest of the dental treatments can be done almost unaltered. A liver disease patient or a patient with jaundice has got a lot of complications possible in him or her. There will be coagulation issue. There will be an immune deficiency. There will be healing problems. There will be drug metabolism issue. There will be high infectivity for the patient as well for the operator because it could be viral hepatitis giving rise to the jaundice or the liver condition. And there will be oral manifestations as well. So this is probably one of those slides to take a quick snapshot of that liver disease. As soon as you hear this, these are the things that you have to think about. Are we looking at any of these or are any of these possible? On the hindsight, there are other things like viral hepatitis could be acute or chronic, infective hepatitis of non-hepatitis virus origin. There are other cytomegalovirus and other viruses which can give rise to hepatitis. Alcoholic or other non-infective hepatitis is also possible, where the infection is not the problem but the rest are. Chronic liver disease and cirrhosis. Now this patient is going into another dimension. This patient could have hepatic carcinoma because that can often commence from cirrhosis. This may be a liver transplant patient. Huge problem. Apart from all these, now you have got the problem of serious immunosuppression to make the liver stay in the body of the patient. So that is another chapter altogether. And I think liver transplant patients are very dodgy patients to handle in chamber dentistry. They are nicer for the dental OPDs in a hospital where there is the hepatologist and gastroenterologist who can handle the nuisance part. And these patients can be in multi-organ failure, eventually coma. I don't think that is important in dentistry. So very wide spectrum of degree of involvement, and therefore guidelines are very elaborate and complicated. The patient has to be classified mild, moderate and severe is what is important for your dental practice. This patient has got a liver condition. Is it a mild liver condition, moderate or severe? It is how you have to classify the patient. All these can happen to all liver condition patients, but obviously the level will be dependent on mild, moderate, severe. What happens to the coagulation? Why is coagulation a problem? Again, I'm not teaching medicine, but it always helps when you know the underlying reason. Liver patient, see, I take examination of different levels of post-graduation. and international fellowships. And these are reasonably seasoned practitioners who answer. And what we as examiners want is, we utter the word liver disease, we want to hear coagulopathy in return, instantly. Unfortunately, that doesn't happen all the time. And we think that it is only natural to happen. When you listen to it, it is only natural. But then somehow these things get forgotten. So coagulation, why is it a problem? If you know that, then you will probably not forget. Due to compromise of vitamin K related clotting factors. You remember we talked about vitamin K in the very beginning about coagulation when we were talking about anticoagulants and antiplatelets. Here it comes. Vitamin K is responsible for too many clotting factors. Factors 2, 5, 7, 9, 10, 11 and 12. So coagulation profile must be known before intervention in a patient of liver disease. Consider tranexamic acid, vitamin K, FFP, desmopressin if coagulation is deranged. Forget about those Russell Viper, Venom and all which are there in the book. Those are for fun sake, trivia to remember. So these are the things that you can use, and out of all these, we have to use FFP and vitamin K from time to time. I have never used desmopressin. Tranexamic acid is something which all dentists should be able to use in liver patients, both systemic and topical. Careful surgery and meticulous hemostasis is important. Limit dental management only to artery ones in acute and in advanced. Mild hepatics are almost normal candidates, but handling with caution and hemostasis static preparations are recommended. So you should have in mind that this patient can bleed, though it is a mild. As I keep repeating one sentence, there is nothing called never, there is nothing called always in the subject of medicine. So be on the careful side, it will help you, not on the scared side that can never help. So that's the issue. You should be ready for hemostatic interventions. So first was coagulation, next comes immunity and healing. This is because of abnormal protein metabolism and polyhypoproteinemia. Almost all the protein metabolic activities that happen in the body's metabolic total arena are liver dependent, and that's why there is high pan-hypoproteinemia. Consider antibiotic prophylaxis, because what are the main humoral immunity elements? The immunoglobulins. Globulins are proteins. So if the immunoglobulins are not there, if the globulins are low, then the patient will be immunosuppressed. That's the kind of underlying story of immunosuppression in hepatic condition. However, must not overdo, as the liver only will have to handle the drugs. So we need to have antibiotic prophylaxis, but not too much of that. Also, there are no standard protocols. Careful surgery, meticulous monitoring of healing, protein supplementation under physician attention when healing is an issue. If the healing is a serious issue, ask for a total protein, albumin and albumin globulin ratio. Get the reports. If you see they are pretty low, send the patient to a good physician to have the albumin corrected. Don't try to correct albumin. There are major issues with albumin infusion. It should not be done on an OPD basis. Let the persons who are good at doing it handle the scenario. Drug metabolism problems. Most medicines are okay. Most medicines used in dentistry are metabolized in liver, and most work in a protein-bound status. Both may be deranged to different levels, and therefore a conscious, careful prescription is important. Not a scared prescription, a careful prescription. NSAID should be avoided for risk of GI bleed and renal failure. NSAID should be avoided. Now comes the real modifications, not the kidney. When the patient has a liver problem, plenty of medicines become an issue. NSAID should be avoided. Paracetamol is okay. We all know that paracetamol can cause liver failure, but paracetamol can cause liver failure at poison doses, not at human doses. A patient who tries to commit suicide with paracetamol can do that in liver disease. But that's not normal. Opioids can lead to encephalopathy at higher dose. I don't think any of us are using many opioids in dentistry. Paracetamol is reasonably safe. 2 grams per day is fine. 2 grams a day is good enough, isn't it? 650 milligram into 3 still doesn't cross 200. So at the 2000. Morphine is very safe, but again you are not going to use it in the dental chamber. Keep drugs to the minimal to relieve pain. Lidocaine should be limited to 300 milligram. However, that is the normal maximum dose anyway. So there is no big deal. So you can use lidocaine like a normal patient. Prilocaine and articaine are safer, but we don't usually use prilocaine and articaine in our routine practice. Lidocaine up to 300 is safe, then it's fine, we will use lidocaine. Special care and GA consideration, very important. Let the anesthetist be in charge of it most of the time, unless you are doing major maxillofacial surgeries where you have to consider specially about the hemostatic issue. Penicillin and chromacin are safe, but vancomycin is not safe. We hardly use it, but at the end of the day, don't use it in liver conditions. Metronidazole, clindamycin, and tetracycline at last. These are to be avoided in a liver disease patient, in a bad, moderate to high liver disease patient. So first time I got something to say no to. Mostly I say everything is fine. Here, avoid these. You avoid NSAID, you avoid metronidazole, clindamycin, and tetracycline in liver conditions. All azoles must be avoided. The only azole we normally use is fluconazole. It must be avoided in liver disease. Nystatin is a safe medicine. If the patient has got a liver condition and has got a lot of fungal issues in the mouth and you have to prescribe something, that's when you use the nystatin lozenges. They're fantastic medicines, but it is not in common practice in India. It is available. It is highly available in India, and these are the cases where you use nystatin instead of fluconazole. Finally, carbamazepine, don't use benzodiazepine required to reducing the dose. Carbamazepine, Tegretol we use for trigeminal neuralgia. Don't use if the patient has got a significant liver condition. Benzodiazepine we rarely use, but we do, and that is also to be dose modified. All hepatitis are not infective. However, universal precaution is all for all. So I have not gone into deep detail because there is another slide which I will not cover today because that's another slide. Just you can read it up. It's simple. There is something called universal precaution, and because universal precaution is supposed to be practiced in each and every patient, I have nothing to say special about a hepatitis patient. Hepatitis patient is fine. You can treat a hepatitis patient if you are really following proper universal precaution. Oral manifestation of liver disease, well, there they are. I don't think it's extremely important for dental practice, but yeah, these are the conditions which you see in liver conditions. In a liver transplant patient and in end-stage hepatic case, plus an immunosuppressed transplant case. So we have discussed about the two separately before, we just match those two up.